We are live now.
Okay, friends. Ortho TV, can you give me the, if I want to mute everybody, can you give me that power?
Yes, sir.
Because otherwise you people disappear and I have a problem here.
Yes, sir. I am made your co-host.
Okay, thank you.
Thank you, sir.
Okay, friends. We start now. Can you see my screen or no?
Yes,
Yes,
we
sir,
can.
we can see.
Are you seeing the screen?
Yes, sir.
Yes.
यार हमको
Yeah,
कैसे
yes, sir.
Please say if you see this my screen, please say you can see it.
Yes, we can see it.
And let the presentation come.
Yeah, we can see it. Strong cervical fracture, yes.
Okay.
Yeah.
Okay. So we all know about the transcervical fracture. Classification, which to me is not very important, but the Powell's classification, which is based on the angle of the fracture line, which we all know. This is the comparatively a horizontal fracture. This is a 50 degrees, this is 40 degrees, and this is 70 degrees. This is how the Powells have classified. And the one which has the problem, the healing is this 70 degrees, which we all are aware of. The Garden classification, which is based on to the trabeculae. Garden 1, Garden 3, and Garden 4. Yes, they are all the same. But classification, unless it helps the treatment, to use the area classification. It is only expressing it or recording it for the future that the classification is important. Now, the Garden classification in practice, however, it is difficult to differentiate the 4 grades of the fracture. Therefore, it may be more accurate to classify femoral neck fracture as a non-displaced fracture. There is Garden 1 and Garden 2. And a displaced fracture, Garden 3 and Garden 4. Same thing is here. Displaced fracture, this is grade 1, and this is grade 3. So these are the ways in which displaced fracture has a far better prognosis than the displaced fracture. And this is the Garden 4 or a vertical fracture. These are the fractures which has the worst prognosis of all of them. To me, the neck femur has 4 types of treatment difference classification. So the classification which is to be based on to the treatment, to me, these are the 4 types of it. Now, see, since this is not a postgraduate class, this is what is there. We are talking about is all of us are orthopedic surgeons. So there is the one type which is most important is the valgus impacted. And this is the type which can be conserved for a safety. We may put 3 screws in C2. But this is the second type which is undisplaced but not impacted. This must be fixed. This is like any other fracture, it must be fixed. You can see here, this is impacted fracture. While here it is only fracture, undisplaced, but not impacted. So it must differentiate between these 2 fractures. Now, this is a vertical fracture, 70 degrees. This is reduce and DHS and compression screw across the fracture, which will come to a little later. This is what is the treatment of that. And this is the 4th one, garden 4, fully displaced with posterior comminution. If 60 plus, it's better to replace with the THR and not with the bipolar. But in a young, we'll need most of the time open reduction and a DHS, but it has a high complication rate. So this garden 4 and this type of a fractures are the ones which will create problem to you. When you're treating the fracture, you got to know what sort of a fracture which you are treating. Portable poor X-ray in a ward when the limb is lying in external rotation is not a definite decision-making X-ray. So many times in the cities where I work in Bombay, patient wants to know if there is a fracture and then only he wants to go to the hospital. So they get this portable X-ray done in the ward or in the house. Most of the time that technician who comes, he takes the X-ray wherever it is lying that is in external rotation. It's not a definite decision making. If the femoral neck fracture is suspected, an internal rotation view of the hip must be to identify a non-displaced or an impacted fracture. If there is a pain in the hip joint and the patient cannot walk about, he has a fracture. Either is the neck femur or is a symphysis pubis, but he has a fracture. There is nothing like a sprain or a soft tissue injury. If it is a soft tissue injury, he can walk about and he can move about. So that is the one thing which is a very clear cut about it. Now you can see this is the X-ray taken at home in an external rotation. You can see there is probably suspicion of a fracture here, but not sure. But when you take an internal rotation view, you can see now the lesser trochanter is internally rotated. Now that fracture is quite visible. So you can easily treat this fracture with the treatment, which you can see it over here. Now it is seen a little better. But this wasn't seen at that time. If you don't see, then you will treat it conservatively as if there is no injury. Now here is a fracture in 2006. 75-year-old fall, pain in the hip, cannot walk without pain. Once he couldn't walk without pain, so the X-ray was taken, internal rotation view. No obvious fracture. If there is no obvious fracture and the patient has a pain, cannot walk about, there is no fracture in the neck or there is no fracture in the pubic ramus here, then you have to suspect that probably this is the fracture which is not being seen in the X-ray, and in order to rule out, you need an MRI. Once you do an MRI, you've seen this fracture very well. You can see this fracture very well. In the hindsight, now after seeing this fracture, you may feel there is probably a fracture here. Basal type of a fracture. So this was the fracture which was detected. Now the fun was, this is probably the fracture. The fun was, Rizzo and Godet have mentioned in JBJ 93, MRI provides an early diagnosis of an occult fracture about the hip and may decrease the length of the stay in the hospital by expediting a definite treatment. So this was the fracture which I detected it. MRI shows fracture which was not apparent on plain radiograph. This 71-year-old patient refused fixation as she herself couldn't see the fracture. He said, if there is a fracture, I should be able to see. So she refused fracture. Now this is what is This is 14 weeks. The same area which was fractured. Now you can see it very clearly.
Sir, would CT show the same fracture?
Sorry.
CT scan would show the same fracture.
Yes, CT scan will show, but the MRI will show good signal changes. The CT, if it is undisplaced, may not be able to pick it up so early. MRI is a better option than the CT scan. But if you don't have an MRI in your area, or it is impractical to get an MRI, then the CT will do almost the same job.
Sir. Good evening, sir.
Any other question?
Sir, Asim here.
Hello, Asim.
That's a misconception. If you get a CT, you will have to order a fine cut CT and you will have to go to the console and see all the images. Otherwise, what radiologist caters to you may not reveal the fracture, one. And second, it's a misconception. If you are hunting for a fracture, whether it is scaphoid, talus, neck femur, if available, you should always order an MRI and not a CT scan.
Now, I think the issue is, in some cases, MRI is not there.
Suppose it's not there, it's okay, but now MRI is like,
Yeah, everywhere it is available.
yeah, in Indore, there are at least 15 MRIs, more than what they have in whole Bangladesh. Yeah.
So it's too big a city.
Yeah.
People come here from all parts of India, and there are few people who are from outside India, from African countries, I understand.
Yeah.
Anyway, I think what your point is absolutely valid. MRI will be 100%, CT will not be that good. So if there is a choice, you must ask for an MRI. Now, this was the fracture which was there. Again, in another 3 months, 22 weeks, it is like this. 71-year-old. Ultimately, you can see at this stage, it could have been 100% normal by fixation. But this change is this is how it went from here to here to here. And as you can see, they are so badly displaced. And in a 71-year-old, the treatment was obviously a replacement. Totally implemented bipolar at that time. In conclusion, till now, X-ray of a suspected neck femur, if normal, is not necessary. X-ray report of a wet portable film by radiologist is very dicey because the film is taken by a technician. Internal rotation view is a must. And MRI is still negative suspected case is almost final. For treatment, internal rotation with traction under anesthesia is most informing. You will be able to treat the patient in the best possible way. Neck femur treatment plan. Now conserve. Most of the time, on day one, if you see the fracture, you will not conserve. Conserve, which is the fracture you can conserve? Impacted valgus fracture. This, if it is impacted like this, now it is the patient is, generally this is not going to shift, but you are not 100% sure. This is a non-displaced fracture. This is not the one which you will conserve. This is the fracture which can be conserved, but I have my own problem and I have my own reservation about it. This was the fracture and this is the 3 days old fracture undisplaced. This is not the one which you think of conserving. Valgus impacted, conservation may be okay, but undisplaced but not impacted cannot conserve. Now both valgus, distinction between these two is impacted and undisplaced, as you can see here. And you can see here, this is impacted fracture. Now this fracture was the undisplaced fracture. 3 days, 6 weeks, it goes displacement. So undisplaced fracture conserved and displaced in 6 weeks time. So you cannot conserve this fracture. Now even this valgus impacted fracture, this type of a fracture may be conserved, but this type of a fracture again cannot be conserved because this is the one which is a totally different type of a fracture than this fracture. So when to conserve, my rule of thumb It's a valgus impacted fracture when the patient comes walking full weight bearing with little pain. An X-ray shows a fracture surprisingly. When the patient comes walking full weight bearing with a little pain, an X-ray shows fracture surprisingly. This is the fracture, and he has history of 10 days or so of injury, and he has walked on it. So now it is safe to pronounce conserved. It's a valgus impacted fracture, no pain, and 10 days of full weight bearing has not displaced the fracture. Same fracture on day 1 must be fixed, not to take any chance. Decision is not whether to conserve or no. Decision is what surgery. So to me, transcervical fracture, conserving is only in that peculiar situation when the patient arrives late after walking about and moving about. So timing of the surgery, younger patient fixed urgently, but delay of 24 hours or more to achieve a medical stabilization have been shown not to increase morbidity or mortality. So there is no need to do a middle of the night surgery. You can do it the next day or even after 24 hours. It has not shown to have any other problem. Saxon and Lennart also found that early surgery was detrimental to medically unstable elderly hip fracture patients. Many studies, 24-hour delay doesn't make a difference. 75-year-old friend of, I was on a holiday with a friend who was 74-year-old. He had a fall and I suspected fracture neck of femur. X-ray was not available on the holiday resort. We were about 7 hours away from Bombay. How will you treat this if I ask you on the holiday? How will you manage it and how will you transport it and how are you going to do the job? Anybody wants to answer? Anybody wants to answer this? Yes, somebody?
असीम सर
नहीं तू क्या?
हम नायर से जानता है.
Skin traction.
Huh? Nobody wants to comment.
Sir, skin traction.
अरे इधर हम लोग हॉलीडेज पे हैं एकदम.
Sir, we can.
What town we are staying and my friend got a fracture. He had to go to
Sir-
Bombay. फिर क्या कर सकता है?
Sir, we can give a long list of splint.
Okay. Only thing on the spot I did was to pass a catheter before the ambulance for a 7-hour journey. You will have to adjust the hip. Give a painkiller.
पाचशे 9 आहे. मग सरांना विचार की नाही सरांना फोन करून विचार की तुम्हाला बघायसाठी पेशंट आहे त्याची शुगर आता 509 आहे काय करू.
I have muted all. Those who want to comment, please unmute yourself and then talk. So this is the only thing I did was to pass a catheter and send him by ambulance, giving him a painkiller and adjusting the hip in different positions by the pillows. This is a very good example, Dr. K.T. Dholakia, the doyen of orthopedics in Bombay. He got a fracture neck of the femur at the middle of the night when he went to the bathroom. And being too nice a person, he didn't want to wake up anybody. So from 1 o'clock onwards, 8 o'clock in the morning, he got the people to shift him to the hospital in ambulance. And for 7 hours, bladder was full. And he went through a lot of problems related to the urinary tract. So the main thing I think in outside, if you get the problem is to pass an ambulance, before going to the ambulance, pass a catheter and then send him. Neck femur treatment plan, close reduction. description of the closed reduction is in the traction, give a traction. Now, generally, all what we do is to traction, and internal rotation is the one which we do that, and then the fracture gets very well reduced majority of the times, because the other link is there so that you can put in the CM in a proper AP and lateral position. The description which is there is traction and external rotation to disengage the fracture. Now abduction to bring distal fragment under the neck. Now internal rotation to correct apex anterior angulation. And finally adduction to lock the fragment. Asim, have you ever done that? Any of you?
No.
You never done that, no?
No. You just give the position and just make the lower limb look like what it should be.
Yeah,
It does all this maneuver. If it's going to fall back, it will fall back.
that's right. So all this is a book picture I am
Yeah.
putting down is not done. I have never done it. Asim has not done it. And any other faculty around? So nobody has done this. So basically all what we do is traction and internal rotation, and this is it. Yes, Namrata, what do you want to say?
Sir, there are so many methods of close reduction described in literature. So, is there any one thing you prefer or you prefer not to reduce before?
Leadbetter is the other method which is described. They put
Yes,
it-
sir. Flynn.
Sorry.
Yes, sir. There are multiple methods. So, is there anything you prefer, or do you think
So
that?
I only prefer anesthesia, traction, and internal rotation.
Okay, sir. Thank you, sir.
Leadbetter should be banned. It should be. Yeah.
Asim,
It should be banned.
to me, the Leadbetter method is contraindicated because it will harm the thing than help.
Only one or two attempts, or maximum maybe 3 attempts at a close reduction. Otherwise, you just proceed with your surgery and SOS resort to mini, semi-close, mini open, whatever you call that, or a full-fledged open reduction. Don't keep on trying for 30 minutes that it will reduce.
Because multiple things will again damage the head rather than help.
Sir,
Yes.
Dr. Gade Gone Marshall.
Good evening.
Good evening. Sir, these are all methods described in literature. They are all violent methods. They are doing more harm than good to the patient. So gentle traction by manual traction and internal rotation gives in 90% of the cases, the fracture is reduced.
Perfect. So all of us agree, all the faculty agree that all other methods are harmful rather than helpful. You must get an anatomical reduction. Not an acceptable, but anatomical reduction. 160 degree, 140 degree, whatever is the way. And you can reduce it if in case you are not getting a reduction by joystick method. Joystick 2 thing goes here, you can disinfect the fracture and get the fracture back. And you got to see at the end of the reduction, these two S's are matching. And confirm that it is a good reduction. If there is no good reduction, the fracture will not heal up properly. Now here was the fracture. You can see impacted, slight posterior tail, not possible to correct all the time. Unless you decide a joystick. So this can be in situ fixed up. This is the only one which is a non-anatomical fixation, which will probably work. But in a lateral view, to me, this is not accepted. And that's the reason this is not the ideal treatment for this fracture. I think it should be treated like this. It should be treated like this, reduced and do it. Like here. This is the one.
Sir, just a minute. Can you go back to the previous slide? Yeah. You rightly pointed out with the red arrow that if head is going posteriorly on the lateral view, 1 or 2 millimeters, that is not acceptable. And if you look at the hook and the drawing on the right corner, the shaft fragment is 1 or 2 millimeter behind the head fragment and it's supporting. So on the AP view, if shaft fragment is hugging the head, cupping it and supporting the head, and inferior border of the head is 1 or 2 millimeter above the margin of the neck, that is acceptable. And on the lateral, what has been shown by sir with the red arrow, and on the drawing on the extreme right, that is acceptable. So this is something Dr. Agasha about 15 days back, he pointed it out, is something reverse of IT. In IT, what we now talk about is a positive reduction.
Particle peak.
Here it is here it is reverse of that, which is good. This one is good drawing. Yeah.
Similar impacted fracture.
Yes.
This is the way it has been reduced. First K wire is put till the fracture. Now this screw is put, and you can see the screw is turned. So this fracture is turned, it is reduced, and the guide wire is put back. This is the one which has been joystick method. You can reduce this. You can be added with putting 2 K wires or a small thin Stillman pin into the head, and you need to do that. As I mentioned in the previous one, that time this is so much impacted that you will have to put in the hook and pull it out, disimpact it. Then only you will be able to reduce. By this method, this is on the Google. This method you may able to get, you may not be able to get. My choice is all the time, if you don't get it like this, put in a hook in the fracture and disimpact this. You will be able to disimpact, and now you will be able to get a good reduction and a fixation. If you do not get a good reduction, even after a joystick, open reduction is a must. To me, only anatomical reduction is best except minimally valgus impacted fracture. If that anatomical reduction is not achieved, do not hesitate to do an open reduction. We must master the open reduction, basically 2 possible incisions. Watson-Jones, which is commonly recommended in practice, Smith-Peterson, which is the second option. So put on the fracture table, but without the traction to manipulate the limb. You can put on the fracture table, but take the foot off the traction table so that you can manipulate the limb while doing the open reduction. Incision begins 4 centimeter posterior to anterior superior iliac spine. This is a Watson-Jones method. Superior, extend to the tip of the greater trochanter and then parallel the posterior border of the greater trochanter to his inferior margin. Subcutaneous tissue reflected facial lata on which the tensor facial lata muscle can be seen. One must resist temptation to perform open reduction on a fracture table. This unnecessarily compromises the surgeon's ability to disengage the fracture fragments and manipulate them into reduction. Now, this is the in between the tensor facial lata and sartorius, that is the Watson-Jones. And between the gluteus medius and the between the gluteus medius and the tensor facial lata is the Smith-Peterson, that is anteriorly. I'll come to that. Now, both of them, once you reach, this is the Smith-Peterson and this is the Watson-Jones incision. Initially, I was quite fond of Smith-Peterson, but now I have changed over to a Watson-Jones because from one incision only, you can do the fixation. With Smith-Peterson, you will have to do one incision here to reduce and second incision here to fix it up. So once you have done this Watson-Jones, now in both of them, treatment is the same. In both of them, you go down. Here is the picture of the Watson-Jones. This is by Dr. Rajiv Chaudhary. You can see he has done this. Now he has come to the capsule after taking off the muscles. And now he is is making the cut in the capsule. And then you can see the head. Now still the whole dissection is by a joystick. You cannot see like what we do the open reduction in the shaft. This is still by joystick. By joystick you do it, disimpact it, put the fracture, see it in the C-arm, and then carry on. And this is a Smith-Peterson. Lateral cutaneous of the now. They are all there in the book. You don't have to really see. This is a white line. This is a very direct approach. You are bang onto the fracture. Sartorius is taken away. And now you are on the fracture. Okay.
હાલો હા જાદવ સાહેબ
હા મસ્ત હા સાહેબ
એક્સરે માં આવતું નથી સાહેબ કઈ દેખાતું નથી
તો પછી
સાહેબ એક્સરે મારો
after opening the capsule with the after opening the capsule, here it is, you are trying to pull it out and reduce it and put in a temporary K wire. So the opening the capsule with the the incision K wire may be inserted into the femoral head to act as a joystick to facilitate.
Sir, can't see the screen.
Can't see the screen.
Yes, I think it is. Hi, Rajendra.
Good evening, sir.
Evening.
Sir, good evening.
Good evening. Good evening, Nagi sir.
Nice to see you.
Still not seen.
Something the problem with the Wi-Fi or with the internet?
No, it is only sharing. So I think it would be better if you log in again or
That's what I have done just now. In the meantime, open reduction, unfortunately, very few people do it. It's only some of the experienced people only do the open reduction. Majority of the people don't think of doing an open reduction. And I'm quite surprised. Each one of us are talking again and again and again and again about open reduction if needed. But not many people do it. So I feel the open reduction is required if in case not being able to get a job. I remember operating upon orthopedic surgery. I want to know how an operating orthopedic
બનાય પછી ભાઈ હાલો ના ચાલુ રાખો તો આવત
Ortho TV also make me co-host. I'll keep on muting.
aware of open reduction. So I just talked about, come on, let's do the open reduction. So no, sir, do open reduction. Please do the fixation in situ. Obviously, I think he told me this. Then difficult for him to go ahead and do an open reduction. It ended up.
Now we are able to see, sir.
Where I left. My screen.
Request to everyone, please mute yourself.
You can see my screen.
Yes, we can see now.
Yes, we can see.
Yes, we can see.
Now, this is the key to the whole thing. Even if you do the open reduction, you have to still rely on the C-arm. It's the absolute must. So here the fracture reduction is maintained and transfixed with the K-wire. So if the clamp is very important, this is what is maintained, is transfixed. Open reduction is indicated in the majority of the young patients sustaining high energy displaced femoral neck fractures because they are high energy and generally posterior comminution and they do not reduce so easily. So they are the ones who need the open reduction most of the time. This group rarely reduces with the closed reduction maneuver and it is imperative to restore anatomic femoral neck position. It may be considered in older patients in whom anatomical reduction cannot be achieved with closed technique. Reduction of the displaced fracture almost uniformity in opinion. Non-displaced fracture neck of femur should be stabilized with multiple parallel leg screws or pins. Young active patients should undergo open reduction and internal fixation for displaced fractures. Perventile, only one gentle attempt at closed reduction. If perfect reduction is not obtained, must do an open reduction. Under no circumstances, repeated vigorous attempts to done for a closed reduction. Only Gans, the one who talked about the dislocation of the shoulder, about the hip joint while operating surgical dislocation. He overemphasizes. I never do closed reduction. It's an intra-articular fracture. He over-exaggerates his position. He says, I open up every neck femur of the fracture rather than burn my balls under CR. Open
મને ખબર કઈ તારીખે માર્યો હતો 21 દિવસ
11 તારીખે માર્યો આજે 28
Open anatomical reduction in DHS with short plate and a derotation through proximally achieves 100% union. AVN rate is the same. So AVN we are not counting, but if we do the good reduction, the healing is going to be almost assured. I cannot overemphasize more than this. Still, all of us do not do open reduction in the fracture often enough when required. The rates of revision surgery approach 30% when treating displaced femoral neck fractures with complications include pain fluid, hardware, non-union, and AVN. Posterior comminution is an important cause of insecure fixation. More than half of the insecurely fixed fractures end up in a non-union. Despite attempts to impart stability to the fracture by different methods of internal fixation and by a combination of posterior bone grafting and internal fixation, the rate of non-union is still between 10 to 20% in a posteriorly comminuted fracture. All this has been tried out. So if you find a posterior comminution and that is suspected, probably the CT scan will be better to really understand that. And in the person above 60, 65, a total hip may be an option which you will have to consider. Non-union and osteonecrosis continue to be problems following displaced fracture ecostemia. The rate of non-union has ranged from 10 to 30%, and the rate of osteonecrosis 15 to 33%. Once anatomical reduction is achieved, temporary fix with wire till definite fixation is done. Now fix with DHS and a short plate and a 1 anti-rotation screw or 3 screws, whatever it is. My choice is DHS with the short plate. 3 screws for those who have faith in it, we have a choice. Here is the fracture. Open reduction was done, treated with DHS and things. You can see the open reduction 6 months time, the fracture is held up. For surgery, after an excellent reduction, 3 parallel screws can be done. Screws resting upon the cortical bone of the femoral neck, both inferiorly and posteriorly. This screw fixation, it is a method which I'll describe. Sequence of screw placement. This has been beautifully described in Dr. Anand Thakur's book. Initial guide wire is placed on the inferior neck in an AP view and a central on the lateral view. So first wire is here. Second wire is placed on the posterior cortex in a lateral view and center in the AP view. And third is proximally in APA. Third is proximally in the AP and anterior and in the center in the lateral view. These are the 3 wires, 3 screws which have been recommended. Parallel screws is the one which we have been talking about up till now. We'll come to later on the other implications of non-parallel screws later on. This is what is conventionally done by majority of the people today. Multiple guide wires in place, the traction be released. Gentle blows applied to the lateral cortex in line with the femoral neck allows the fracture impaction. If there is a need for increasing valgus in the reduction, then the first screw can be the proximal screw. When you tighten it, this fragment will go into a little valgus. The bigger screw should be tightened first, followed by remaining screw. This is what is Dr. Anand beautifully has described. First screw is here, the character and center in the is posterior cortex and center. And third is center. After screw placement, the femoral head should be visualized by image intensification during the full arc of rotation so that you are not penetrating the head. This will verify that screws are not violated the subcortical bone of the leg. This should be performed with both anterotation. Post of regimen, walk up to the comfort. There is no point in putting the non-union. You've done a good fixation. And if you haven't done a good fixation, plaster cast or walk with the stick. Non-weight bearing doesn't prevent complication. Here is the fracture. This is the bad reduction which was done. And this is how it is fixed up. This is destined to fail. These things have backed out and it has failed. This is what is going to happen. So, just because you put in 2 screws, the reduction is the part of the operation. Screw fixation or a DHS. Perfect position in the screws placed like this, the fracture can there is a perfect reduction in AP and lateral. DHS is better by AO for all.
नहीं चल रहा हूँ मैं अभी.
DHS, the short side plate is considered better by AO for all fixation, intracapsular or stability. And you can see the newer implant which has come, FNS. It applies the same principle, which will come to a little later. How to do a good DHS. Now that this is the next talk, if at all we talk about. Now, I want any of the faculties who have joined, like I see Gadi Gune, I see Chandok and Asim. And if anybody, Naveen Thakkar or Sangeet, anybody has joined, please, you want to add up anything, please contribute here. Chandok, you want to add up anything?
Sir,
Yeah.
may I add something?
Yes.
3 screws will work, if at all they work, only when lateral cortex has got a very strong bone. If lateral cortex is not strong and bone is osteopenic, then you ought to do a 2-hole DHS and a derotation screw, or newer designs like this new system. Don't do the screws if you are not very sure of the purchase on the lateral one. And every single paper in the literature goes on showing that DHS has the least complication rate, but still I think Americans are obsessed with screws.
Yes, Dr. Rajendra, your opinion?
More near the fracture, near the subcapital line, 3 screws may work, but more it is transcervical and more towards basal, DHS becomes essential.
I think my rule of thumb is, if I am fixing up an undisplaced fracture, I'll fix it up with the DHS. But if it is a displaced fracture which needs close reduction, even by a joystick or close reduction, I always do a Karigune, your
Sir, may I always prefer a DHS with additional screw.
anybody else wants to comment? Anybody, participants? Now, anything you want to ask about the fracture neck of the femur? There are so many.
Sir, in subcapital fracture, is DHS safe? Like I have seen it getting failed in subcapital because of less hold of DHS.
That's right. But still, as Dr. Asim mentioned, Americans still feel 3 screws is the treatment, while the Europeans are still talked about the DHS. And now the newer implant which has come, FNS, which will come to, which combines these 2 treatments. Anybody else wants to ask anything or any clarification?
I would request, there are so many questions about intercapsular. Don't be shy. I think it's a very good platform to interact. So,
Sir, then what should be the implant of choice in subcapital fracture? Like if I have a patient with subcapital, which one should I go with?
so if I can answer, sir, that. So subcapital and a small head, I would prefer 3 screws. Subcapital, say a small stretchered lady somewhere like 5 feet or 5 feet 5 inches, some less than that, and the head size is small, then it makes sense to give 3 cancellous screws in the desired situation. If head size is good, fracture is unstable, then my preference would be more towards a DHS.
Sir, what is cutoff age?
Sorry?
Sir, may I ask?
Yeah, go ahead.
Is open.
If you are fixing fracture neck femur by 3 screws in a reverse triangular fashion, do you advise a fully threaded or a partially threaded screw for the central inferior one?
We'll come to
that to prevent the varus of the neck.
Newer concept of the fracture neck of femur treatment will come to probably next. At the moment, we are talking about conventionally done thing. So what your question is very valid. We'll come to that a little later.
Okay, sir.
Anybody?
Yes,
regarding
sir, can I ask?
Yes.
Sir, what is cutoff age for fixation?
Good question. I think if you ask me, who is working in South Bombay, for me the cutoff age is comparatively not very high. But you ask Dr. Garigune, he doesn't do fixation, he doesn't do replacement often enough. He does fixation in all of them, and he is, because he treats really very poor people in a very small town. So I think indication for a replacement and fixations are totally different in different geographic areas.
Yes, sir.
I work in a South Bombay, which is probably the richest part of the country. And there, I wouldn't hesitate doing a replacement with the ceramic on highly cross-linked poly, where the patient will spend 5, 7, 8 lakhs rupees. Same thing cannot be done by Garigune in his part of the world, because I think the patients are not in the zone. Dr. Garigune, your comments, please.
I think he is switched off.
So regarding putting DHS with derotation, first we should put DHS, then derotation.
Good question. I was going to talk about the good DHS. As I said, good DHS, you first put in the screw proximally, and then you put in the screw so that you get a valgus correction, and then you put in the DHS screw, which will be a better option to do it. But we'll talk about the DHS, how to do a good DHS.
No, what is the sequence of tightening of the screw? We should finish with the DHS, then we should tighten the derotation screw.
The derotation screw, which is more proximally tightened than.
Yes. Yeah. It should be tightened. We should finish the DHS, then derotation.
Sir has already answered. So put the derotation screw, just tighten it enough, then is the DHS, then DHS is appropriately tightened, and then if required one more turn, you can give that shot.
First derotation, then DHS.
Yes.
And in the DHS, we put a small compression screw. It should be done in the neck femur or not?
Yes.
Yes, it should be. Most of the Indian patients, we would always do that compression screw. However, in the Campbell, it was mentioned that once the compression is achieved, we can remove the screw. We keep it in C2 always.
Because if we remove that, then it is a, we can reach, it can, function of the DHS, it can collapse. It's not recommended, I think, in neck of him.
Also, screw doesn't stop collapse.
Okay.
Actually, sir, Dr. Chandak said you compress the top nut in the DHS, but before putting screws on the side plate, you release the traction. You release the traction, and having done everything else, user starts, I replace my short threaded derotation screw with a full threaded screw nowadays. Almost last 10 years.
As there is a lot of echo, we will request most of these speakers should be switched off. Yeah, now we can.
So what is the after what duration we should not replace, should not fix the fracture? Like 3 months or 4 months?
No.
Just a minute. At the moment, we are talking about the fresh fracture. This fracture neck of the femur will go on for about 3 to 4 weeks. We'll talk about abduction osteotomy, we'll talk about non-union, how to treat non-union, and everything, but the delayed presentation and everything we'll talk about. So at the moment, we talk about the first. There is no confusion into the minds of the people. So fresh fracture, as I mentioned, choice of treatment for me and for quite a lot of things is DHS. So first is a 100% reduction if needed, open reduction, and then transfix the fracture. First put in the derotation screw proximally and tighten that screw. After putting the guide wires, and you can put in the guide wires which can go even through the joint in order to avoid the rotation of the head fragment while putting the screws or a DHS screw. So first 2 guide wires is a must, and then fix up the proximal screw and tighten it. Once you tighten it, now you put in a DHS and tighten the DHS and put in a side plate. 1 or 2 hole side plate is going to be good enough. If anybody now has a question, then we will be asked about it, or if any of the
when to release the traction, sir?
Yeah, you before the plate, you got to release the traction.
Yeah.
So
first derotation screw, then DHS, then we will release a traction after putting the plate, side plate.
All the faculty agree?
So first, I would do a derotation screw.
Yes,
The
sir.
DHS screw is now placed to the point where we want to put it. Then the side plate is put in. The side
Yeah.
plate is attached firmly with both the two screws, usually put two screws. Then the derotation screw is just inserted and is in position. Now is the time to release the traction.
Okay.
So there are two questions which are there on the chat box. What would be cervicotrochanteric fracture best treated by DHS? Dr. Mohammad Yasir has asked.
A cervicotrochanteric fracture, that is the one which cannot be treated with 3 screws. It needs a DHS.
Yeah, so I think that is well answered. And one more question is, can PFNA2 be used in well-reduced fracture neck femur? This is from Aditya Panda.
PFN.
PFNA, yes, PFNA.
Probably out of normal usage, somebody can probably throw a PFN in a transcervical fracture, but that is not the standard treatment.
Yeah. So I think that is a off-label use or a non-recommended use or a adaptation use, not a recommended thing.
Do we need to tap the DHS screw?
I come to that DHS, how to do a good DHS. My next talk is that how to do a good DHS.
Thank you, sir.
So are there any special maneuver that can be used to reduce the neck femur that doesn't reduce in traction? Do you release the traction table again, then abduction or some maneuver or trick to help it reduction, close reduction? And second, what is the X-ray that you see in the OPD and you feel that this is a tough case for neck femur?
Have you joined just now, Harpal?
Yes, yes, he just joined.
Arjot, you joined just now? Arjot, you can hear?
Yes, sir. Yes, sir.
You joined just now?
Yes, sir.
Well, I think we have already spoken about it.
Okay. Okay, sir.
Probably the whole thing will be given to you tomorrow or tomorrow morning it will be there with you.
Okay, sir.
Anybody wants to add up anything now?
So Harjot's question, this question was very interesting, sir. How do you decide looking at a X-ray that this is going to be a tough case?
Transcervical fracture which is displaced. It is a tough case every time.
Yes.
If you get a reduction, you are lucky, but you are never, if it is a fully displaced fracture, you are not all the time very happy for the reduction. If you are happy with the reduction, you do a joystick and ultimately end up doing an open reduction. So fully displaced fracture in a young man, and if you've done the CT scan, the posterior combination is the one which is probably the least easy operation I would consider. Sangeet, you want to add up anything? I see you here.
No, nothing, sir.
Sir, I've got a question to ask, sir.
Bolo.
Which is preferable, sir, pediatric DHS or regular DHS for intracapsular fracture neck femur?
I think mentioned by Dr. Chandok, if the patient is very small built patient, 4'8" and 5 feet tall, then probably pediatric DHS may be all right. But otherwise, in a normal patient, probably the normal DHS will work equally well.
Okay, sir.
To add up anything? Chandok, anybody?
I think the indication for pediatric DHS is a small size head, number one. Number two, if you are doing a reconstruction and the previous other section of the femoral head has been eaten up and you want to do a reconstruction with fibula using this inferior sector, that is another place where we can think of using a pediatric DHS and a pediatric patient. This would be 3 indications.
Sangeet, have you used the pediatric DHS?
Yes, sir. Apart from that, the polio neck femur, those who have polio limbs and they have a very dysplastic head neck, in them that is the implant of choice because the head size is very small and even basal fracture, where we have to put 2 lag screws, additional lag.
Yeah.
So in them, to control the rotation, the cervicotrochanteric fracture, in which we require multiple screws to control the rotation. In them, that is very useful implant.
Okay.
Aditya Seth wants to ask whether you can use a blade plate for a fractured neck of femur primarily.
Again, it is an off-label use. I think blade plate is not really designed for this. To me, I will not use a blade plate for a fracture neck of femur.
Right.
I see here Kedar Agarwal, a senior orthopedic surgeon from Raipur. Kedar, are you there? Kedar,
Yes, sir.
are you there?
Kedar Agarwal.
Yeah, I'm here only.
तो तेरा मुंह तो दिखा दे.
Hello. I'm sleeping in mode. Next time I'll show you.
अभी क्यों नहीं?
Today I'm sitting somewhere else.
Okay, okay.
Okay.
Thank you, sir.
Okay, now we'll talk about a short thing on a DHS. Just now people asked. The DHS avoiding error. This will apply to both IT fracture if at all you are using it still, and a transcervical fracture. This is really the end of a road in the world. This is the last road in the world. This is when we went to Antarctica. This is in the Argentina. This is the last road. After this, there is no road in the world. It is all sea. DHS, after obtaining a perfect reduction, either closed or after open reduction. I am talking about a standard day-to-day DHS 135 with TAD less than 20. That is the gold standard. This is 135, and this is the 2 trabeculae traversing. So DHS ending up here, and TAD distance 20 or less is the ideal situation. Few points about that gold standard normal closed or open reduction DHS. DHS is 135 degree, the implant. Why 135 or maximum is 140 only? That is the normal neck shaft angle vector of the force. Now this is the vector. This is the weight bearing. Weight bearing, when it is there converted to, this is the force going, and this force is going at 135. And that's the reason when you put in this screw at 135, then it is coaxial with the weight transmission. Then it will also allow you the collapse to occur if in case it is needed. And that's the reason why this 135 is absolutely required. I see so many people using 125, 120 DHS for a transcervical fracture or even a IT fracture. It's contraindicated. I don't think it exists. And into the AO things, it was only 135 and 145. That this was only 3, 135, 140 and 145. This was only 3 implants which were available. Now, how to go do IITs? There are 2 types of plates available, 25 degree barrel and 38 degree barrel. And this is the jig, which is a must when you're doing a DHS. This jig must touch the bone all the way through. If there is a muscle which comes over here and you're putting the jig like this blindly, it will not be 125. This will not be 135. That's the reason this, you got to see that the jig is touching the bone all the time. Because, so you'll have to open up this, get the bare bone and see that the proximal and the distal part is touching the bone. Then you pass 135 degree, then it will be right into the center. Once having done that, this is the way 135 degrees guide wire goes through. This is the 135 degree guide wire, AP and lateral view. Now you measure. You've gone right up to the neck. So you measure here and you measure it and you minus it 10 to 15 degree because you've gone far too. So you measure it and now you have gone and you want the measurement. This is 95 degree you measure. So this is 105, you've taken the 95 degree. So 95 degree is the measurement which you've taken. Now, you must drill first. You must first the drill. Drill all the way. My suggestion is if you are passing a 95 degree, drill till 100. And this is a triple reamer which is there. So you've done the triple reamer drilling up to here and this drilling up to 100. Now you take it out and must tap. Tap it all the way up to 100. 95 if you've chosen, tap it up to 100. Otherwise, what will happen is when you are tightening the screw, the head will spin. So this having done that, now you pass the drill, pass the plate, see that it is parallel. Now push the plate up, and this is the way in which you can do the best DHS. And this is how you've done the DHS. 135 degree, and the plate is lying bang parallel. This is how you put in the screws. You tighten this with the tightening so that the fracture is compressed when you tighten the sleeve. So this is 95. Tap is very important in younger patients. Younger have a very strong bones. So unless you tap, the screw will not be able to go all the way down. So tapping is very important. My rule of the thumb is 95 degree screw, then 100 millimeter tap. If tapping fully not done when passing the screw, if last thread of the screw enters a strong bone which is not tapped, the femur head will start spinning, and that is not desirable. Now you can see the fracture here, reduced, and then tapping is done and everything is done properly. But you can see this is while doing the screw, it got displaced like this. So this is what had happened. Pass 2 guide wires even before drilling or tapping. First is 2 guide wires. Drill and tap fully. Pass derotation screw first. Tap 5 millimeter more for safety, then pass a DHS screw. Because here this what happened, ultimately ended up into a AVN formation. Because of the spinning of the head, it got displaced, and you got a AVN because of the spinning of the head itself gave you the AVN in 3 years, in a 1 year time. So after perfect reduction DHS with derotation screw, first 2 guide wires in the head to avoid toggling. Some suggest to penetrate even the head and bite the acetabulum so that the head toggling will not occur. Drill fully, maybe a little more than a screw length. Tap fully. Do not give up the last tapping. 5 millimeter more than what you want to do it. First introduce the derotation 6.5 or 7 millimeter screw and compress the fracture to get a little valgus. Then DHS screw never allow toggling of the head, which may induce acquired AVN, which if it wasn't there even up before the you started the operation. So this is what is the TAD distance, 10 millimeter AP and 10 millimeter lateral. Basic thing is, these are the 2 trabeculae which is passing. So this is the strongest part of the bone. So even if it goes a little more here, there is no harm in that. Remain in the lower quadrant, don't remain into the higher quadrant. And then these are 2 trabeculae where you can really get the TAD distance also is there. Now TAD distance by Baumgartner, he coined the term TAD. Before that, each one of us were doing the screw only into the lower quadrant. Never we did the screw into the upper quadrant. Lower quadrant, just hugging even if it goes hugging the calcar, it doesn't matter. It will end up here. Still, that is the one which is good one. And resist. Now you do this adequate barrel size. If the screw is ending up here and you put in the barrel like this, this is not good. Because what will happen is, unless the barrel is all the way here, then only it can glide. If the barrel ends up here, the weight bearing will angulate it and then it will not go further up. So you will not get the barrel purpose will not be served. So you must end up the screw right up to the end of the barrel. So the screw, you should be able to see it somewhere here. Don't end up into something like this. So the barrel is above 70 millimeter screw. 38 millimeter barrel is all right. Otherwise, you'll have to put in a short barrel. And short barrel or long barrel, this is the thing which you must practice and see that you get it coaxial barrel and the plate. This was reduced, and you can see here, this was 130 degree and this plate was 135 degree. Now it didn't collapse, so there was a tension here. So you can see there is a small bending has occurred. It didn't collapse at all. This is what was the screw and the plate things. So plate barrel things, lack of parallelism when the screw is 130 and the plate is 135. This has to be avoided completely. And this plate, the screw should go right up to here. As you can see here, this is what has happened. If it doesn't collapse, this is in well positioned. It doesn't collapse, but the fracture collapses. So the screw will migrate up because there is no collapse occurring here. Screw will migrate up and screw will go there. If the screw pass is side plate is 135, but the screw is passed at 125, will not allow a smooth gliding. Most of the people don't use. I work in a hospital where there are 20-25 orthopedic surgeons work. And when I'm doing a DHS, I ask for this 135 degree field guide. And the sister is quite surprised. He says, nobody asked for it except 2-3 people. I think this is what is the issue. People pass a guide wire and then they measure which degree it is and then they pass. Unless it has been past 135, you will not be able to do a 135 degree thing. Now here it is 135, you pass the 135, collapse will occur and the fracture will heal up perfectly well. So why 135 degree, even if it is used, screw doesn't go at 135. Under 35 degree jig is a must to use 135 degree plate. Keeping the barrel completely buried on the screw to allow for the post-operative gliding. If ever air, it has to be 140 and never 125. Rarely in a previously wire short neck, 130 may be required. TAD must be below 20. Conclusion, 135 is ideal, 135 jig is must used properly. 35 plate and 125 screw is no. Screw all the way till barrel. No short screw in the long barrel. Tap head 5 mm longer than the screw. Stabilize the head with the proximal screw first and 2 guide pins in order to do the toggling of the head. That is an absolute must. This is the way 135 degree. You must push it this way. Now, why 135 degree we use it for DHS? While for a PFN, it is always 130 degrees. Because the PFN angle, once you go nearer the inner side, medial side, this is 135 from here. But from here, it is 130. That's the reason the PFN angle is always screw is 130, while the DHS is 135. Only because you're measuring the angle from the surface. As you go more and more medially, the angle required is lesser. Thank you very much. Now this completes the DHS, how to do it and everything. So now if anybody has any questions on DHS and fixation, we talk about it. And now I would suggest any of the faculties, please show any of the cases. Dr. Chandak, can you show that your polio patient which you have done the fixation?
Yeah, I'll just retrieve it and I'll.
You have it there?
Yeah, I have. Yeah, I have on my other laptop. I'll just take it within 2-3 minutes.
Yeah, here it is there. Chandak?
Yes. Same one.
Now, first, any questions on PFN? Sorry, any questions on DHS which I talked about?
So Dr. Durgesh wants to ask. Yeah, go ahead.
Go ahead.
Sir, can you tell me the length of the derotation screw, which is shorter than DHS screw or longer than that?
No, it is generally shorter than DHS screw.
Okay. See, I am putting first Richards, then putting the derotation screw. Is there any difference?
No, I think most of the time, if you have been able to get a good compression, it will work.
If I do the first derotation.
So I think in 80s and up to mid 90s, we always did that. once the AO very strongly came out with derotation screw first and then a DHS screw, I think from 2000 onwards it has changed.
Because that is the one which assures two things. One is the lateral valgus reduction, which is ideal for any fracture fixation. And the second thing is, if the screw is fixed, the toggling of the head by a quicker DHS screw will be avoided.
Yes. And many times this toggling is really very important. Many times, even after putting a derotation screw, I would occasionally add one more guide wire to avoid toggling if you are tapping and drilling a very hard bone or a tough bone.
And as a rule, I drill and tap 5 millimeter higher so that there is no chance of toggling at all.
Yes.
First cortical screw, last one or first one?
What last the first? Sorry.
When you are fixing the DHS plate,
Yeah,
two DHS plate is there.
Yeah.
Which screw to put first or second? Means distal or proximal?
So got your point. So on the side plate, there are two screws, or you are using 3-hole or 2-hole.
Yeah.
So which one to put first is your question.
Is it matters or nothing?
There is a small trick in it. So if the plate is very nicely applied and it is snugly fitting. Yeah, it is entered fully, snugly fitting to the bone. It makes no difference whether you put proximal or distal. However, usually the distal you read more retraction. So if the distal retraction is in position, I would put the distal first, finish it off so that you are left with only one bone spike anteriorly and one posteriorly. So it becomes more convenient to the assistant who is assisting you. It makes no difference.
Only thing I would suggest is, if you're putting a 2-hole plate or a 3-hole plate and your lowermost plate part is touching the bone, but the upper one is not touching the bone, that means your choice of the 135-degree plate is wrong.
Yes.
Because that is the one when you put the screws, the DHS screw will not glide. So you got to see, as Dr. Chandok said, whole plate must be snugly fitting onto the bone. So if it is the way which I am talking about, that means probably you will have to take 130-degree plate now.
Yes.
It is not desirable, but in this situation, that is the better option. This will happen if you are not using the jig to pass the screw at 135 degrees. Yes, Sangeet, you want to add up anything?
No, nothing, sir.
Asim?
But when to release the traction? Sorry, sir. When to release the traction?
Yeah, I think we discussed that the releasing the traction is before putting in the plate. That's what I do it. I think Dr. Chandak said something different. What was that, Dr. Chandak?
So once you have put a DHS and you have put a side plate and then you have put a derotation screw, just inserted it and it is well in position, few threads in. Now release the traction.
So before putting the screws into the
shaft.
No, shaft, you have fixed the DHS, you have passed the side plate, you have fixed the side plate to the shaft. That is all done. Now, once you are tightening the derotation screw, just insert 1 or 2 threads before compressing it, release the traction is what my contention.
Okay.
No, I couldn't understand. First means derotation screw first, then DHS,
right,
then side plate, then cortical screw also.
Yes.
Then you release.
Then you release it. Yeah.
Dr. Tanna sir said before putting the cortical screw.
Before putting the screws on the side plate, Campbell recommended releasing the traction.
I do it like that. Before putting the screws in the side plate, I release the traction. So now here it is, I think few very experienced surgeons are there. I think all of them are highly experienced people and I trust each one of them. And so if everybody has a little difference of opinion, you will have to really understand the situations in that zone. I think you are all, that's the reason this is meant for people who are already practicing surgeons. This is not a PG clinic. So you can understand the small difference which is going to be there between the highly experienced surgeons, either this way or that way. Anyway, any other questions on this DHS?
Yes, sir.
Bolo, bolo.
Sir, in the plate, there is a four screw, so we should use the concept of alternative screw
No,
in the plate.
4 screws because most of the manufacturers do not manufacture 2-hole plate regularly. You don't need 4 screws, but if you don't have, then you can use the 4-hole plate, but then you can use 2 screws, 3 screws, whatever you think like. It doesn't make any difference.
And sir, should we always use the long barrel plate?
Long barrel plate, if the screw length is above 75, long barrel plate. If the screw length is below 75 or 70, it has to be a short barrel plate.
Okay, sir. Thank you.
Aditya has raised a question whether the derotation screw has to be fully threaded or partially threaded.
Sorry?
Aditya has a question in a chat box,
Yes.
whether the derotation screw has to be fully threaded or partially threaded. It's a very good question.
I use the partially threaded.
I start with a partially threaded screw, finish my DHS part, complete that, and then at the end, before closure, I remove that partially threaded screw and replace it with a full threaded screw.
So there is always this confusion of a length stable fixation versus a fixation which allows partial collapse. And that is very interesting.
Dr. Chandok,
Yeah.
the newer concept, parallel screws, non-parallel screws and all will probably come to next week.
Yes, sir.
You and me are fully aware of it.
Yeah.
This is the basic what we have spoken about. And next week will be the absolute today's thought process.
Right, sir.
Any other questions? Okay, Chandak, can you proceed?
Yeah. So
This is a lovely case of Dr. Chandak.
So there are some experiences about post-polio residual paralytic limb suffering from intracapsular basal or subcapital fracture neck femur. So this was X-ray. As you can see, the size of the limb. This was the normal side, and the opposite, the involved side, was a very thin bone. And once the reduction was done, actually we come to know about the implant only after reduction. This patient had gross amount of fixed flexion deformity both at the hip as well as at the knee. So tying on a traction table was not possible at all. So somebody was holding the limb. As you can see in the picture, so somebody is holding the limb in flexion, abduction, external rotation, and the knee is also flexed. So this person was walking on this with a stick support with his limb dangling. So this is the picture. So this was the intraoperative positioning. Patient had a gross fixed flexion deformity, and therefore this position is there. So this is after the reduction. And now was a great difficulty because a routine DHS would not fit in. Cannulated cancellous screw would not be sufficient because the screw angle would be very difficult to fit there. So if we pass a cannulated screw, this would be going here. So this would have been very difficult. So that was difficulty. Pediatric DHS, yes, but then when we mapped onto the screw, so this DHS also was not fitting because the DHS came as only 85. So this was also not possible. So there was great difficulty in selecting. Any suggestions somebody would like to give?
Anybody, any innovative surgeon here?
Yes, Negi sir, please.
Negi, tumko malum hai?
No, I'm not. I'm just trying. It will be something like a blade plate combined with a abduction osteotomy.
Okay.
Some sort of, yeah.
So polio limb and then
DCS. 90-degree DCS.
Yes, 90-degree DCS can also be thought of.
Otherwise, contralateral distal femur plate.
So that also can be a possibility, but then this configuration of the patient was really difficult to get. So configuration for
On this line,
yeah.
the surface almost like this.
Pelvic support osteotomy.
Distal femur plate will be very bulky.
Okay, you can proceed.
Yeah. So what we did, we mapped an angle blade plate onto this, and surprisingly, it came very nicely. Yeah, Sangeet, you want to say?
They have anteverted and a valgus neck always.
Yes.
So this is in about 90 degrees of not a normal reduction. This still requires a anatomical reduction because this is almost 90 degrees.
Yes. So the picture must have been there when the traction was bit lessened by the assistant. It could be. Yeah, I do agree. But then ultimately when we fixed it up, it was absolutely unacceptable. I do agree with your point, what you said. So this was the position how we held the limb. So we couldn't put a Steinman pin also, but this thin limb was there. So we thought holding with the limb was sufficient. So somebody is holding continuously and laterally. What you need to do is to sit down and take an incision, and your guide wires are going bit anteriorly on both the side in the anterior part. So this was the mapping of the angle blade plate, and this implant surprisingly was fitting very well for that patient. So to our surprise, this was the bailout implant on that day. Though angle blade plate is not a first choice of implant for this fracture configuration. And as you can see, this double angle blade plate, this was 120 degree. This was fitting absolutely perfectly. So this was the final X-ray after fixation, and one more slide will be there. And this healed very nicely. The patient was fine, and he went back to his previous position, whatever he had, and that healed. Though the size of the implant was more bulkier than the size of the bone construct. And here you can see, Sangeet, that the angle was restored by the angle blade plate.
No, sir. I don't think so. So that is the reason the angle has not been restored. That is why the plate is off. Where normally in a polio limb, the angle of valgus angle is about beyond 140.
Okay.
And if you see the other view, and the angle blade plate is, I think, 130 or 120 or 110.
I think this was 120.
120. So it is not matching. That is the reason it is not flush with the trochanter.
Yeah. So this was the only thing available which fitted on that day. And as you can see, the head is trying to be on to the superior sector. So I could not have got still more valgus.
No, sir. So what has happened here is very interesting. See the joint, how the head has subluxated out of the socket. Yeah. There is a teardrop. If you can draw.
Yeah. But
the teardrop is here and the head is subluxated out from the joint.
Right.
There is one more view. Yes. Yeah.
So this you feel is because of the lesser angle we chose?
Yes, sir. Yes, sir. Can you see? There is one more X-ray. Can you go back, sir?
Yeah, there is an X-ray with both the hip joints.
Yeah, here. So you can see that here. So this is no. One with the both hips. The post-op X-ray with both hips.
Yeah, this is with 4 screws. The next
no, sir. Both the pelvis with both hips.
Yeah, this one.
Yeah, here. Now you can see how the joint is reduced. So this would be through AP view.
Right.
Yes.
You feel an angle blade plate of 130 degree would have been more.
Yes. 130 or 140 would have been ideal.
Could be. I don't deny that. Could have been more.
Okay. Normally, a higher valgus angle will lead to subluxation like that. How come a less angle has given that type of picture?
But this is probably not a true AP view.
Yeah.
Could
And
be.
we don't know in this patient what was the pre-op actual position of the head in relation to socket.
No pre-op X-ray was available because those views were never taken before his accident.
Okay.
There is a request that all should be muted unless we are speaking. Thank you so much.
Now here was the fracture. Here was the fracture. He came on day 1. High risk surgery, liver was damaged, INR was 2.7, bleeding disorder. They chose to have a trial of the conservative treatment in scapular traction when they were explained the high risk which is involved. But you know, I work in a good hospital where this can be operated upon with the due risk, but the patient chose not to undergo surgery. It would have been an easier surgery on day 1. But anyway, this is what happened now over the 3 weeks time. Fracture didn't heal up and it collapsed like this. In 2 months time, this is how they were hoping even if malunion, it is okay. But this was the fracture in 2 months time. They couldn't walk about, patient couldn't walk about and move about. So this is the stage they came back. We did all the parameters. INR was brought down to 1.6 or 1.7. Physician says, go ahead. So now we proceeded to do the surgery. At this stage, he came up to surgery. Now here it is. This is how it was in a lateral view, fully displaced. This was the fracture and it was already 2 months. So this was the CT scan. As you can see very well how the fractures are lying. To put on the track, this is the CT scan. As you can see, it's badly displaced with the fracture like this. So we put it onto the traction table. This was the typical fracture CT scan. Now the traction table came. Pain in the treatment, fibula or no, I was still debating. Traction table, traction, and there it is. I could get the angle back with this gap. So I decided now to fix it up. This is how it was. I put it with the small joystick here, try to reduce the fracture into this position here. Pass the guide wire. You can see here, I am holding the fracture still. Pass the guide wire, passing the guide wire. Fracture got reduced properly. VHS. This was VHS top screw, tightened it, compressed it. Empirically, I had put in a Ortho as I felt it will help to healing. And then you can see the fracture healed up very well, nicely healed up over about few months' time. And this is how I felt. In 6 months' time, no fibula, valgus reduction. It was the key to the whole thing, and the fracture healed up. Still here, the healing is not very, very prominent, but the patient is painless, walking about, moving about. So as I said, even if the patient comes late, probably there is a good chance the fracture can heal up. Okay, friends, any comments? Anybody wants to have any eye? Any of you want to present a case? Sangeet, Asim.
Next time I will find out a similar patient with the intra pictures and a 5-year follow-up.
Any one of you wants to add up anything? Chandok, Asim, Sangeet, Garigune, Patoli is here.
Sir, there is a point of view that this is a hard data that 140 plate, if you can use, is better than 135. So, any opinion regarding that?
Yeah, I think, as I said, 140, which will give you a better valgus. It is
Yeah.
There is no issue about it.
There is a question in the chat box. How can you assess vascularity of the head? Query MRI. There is no need to assess the vascularity of the head. That doesn't have any bearing on the action, treatment plan. There are other factors which decide whether you want to do osteosynthesis and preserve the head or you want to replace it. The decision is not, it doesn't depend on the MRI.
True, true. Sometimes as a patient who has been neglected, if he comes even after 2 months, and if he's a younger patient, 40, 45, the choice is not there to replace. So I think the choice is still to repair. And that's the reason, as you say, there's a thing said, if MRI and whether there is AVN or no, it is always dicey because after 2 months' time, it will always be hypervascular. It will never be cold. So you are going to
Even at 9 months, we have got close reduction sometimes very easily, without resorting to open reduction.
Sangeet, anything want to add up?
No, sir, nothing.
Okay, friends. Anybody wants to ask anything or present any case, you are most welcome. Anyone wants to present a case? Either this time or next time, you have please present, please don't hesitate.
Dr. Sarath, go ahead.
Sir,
Yeah.
what will be the next topic?
वो आएगा तेरे को.
Okay, sir.
अभी फ्रैक्चर नेक ऑफ फीमर खत्म हो गया. फ्रैक्चर नेक ऑफ फीमर अभी तो शुरू हुआ है.
Okay.
Next time we'll talk about. Okay, I'll ask you now. What is the new evidence in fracture neck of femur which has changed conceptually the treatment of fracture neck of femur? Anybody wants to answer that?
So, biplane double support.
Question. Please understand. What is the newer concept which has come up because of the new evidence or the evidence which has been now being publicized, which has made the change in the concept of a fracture neck of the femur treatment?
So, biplane double support fixation with cancellous screws.
Sorry?
Biplane or double support fixation.
BDSF she is talking.
No, I'm talking the philosophy better. You're talking the way. What is the philosophy of that?
I think, sir, it is the control compression by the FNS system.
What is the philosophy of that? What you say is partially right. So what is
We
the
don't want more compression later on so as to have the shortening.
If I can say today,
Sir, to assess the head perfusion by MRI contrast.
sorry, you are not clear to me. Can you
MRI
repeat?
contrast to know how much is the head viability that will detect us to osteosynthesis or replace.
I think Asim doctor mentioned about it. I also said in a younger patient, the replacement is not a choice. And MRI dependability on viability is still debatable. But I think Dr. Nitin Patil has just now mentioned very rightly the shortening of the neck, which can give you a poor function. That is to be avoided. That is the one which we'll talk next time. So what is the newer evidence which is changing the treatment of fracture neck of femur? Okay.
There is one unanswered question that was, is it prudent to try for osteosynthesis in patients above 60 years? Dr. Sarath wants to know this.
As I mentioned just now, probably Gadigune even tried to fix up the fracture even if he is in 75. Because his patients cannot really undergo a replacement and have the small restrictions of the replacement. They are all have to sit down on the ground. They have to have a Indian toilet all the time. For them, a repair, it is successful 75% of time, is still a better option. Dr. Chandok, who is working in Nagpur, probably has a better choice to do a replacement. Asim is working in Indore, he also has a better choice. He and Sangeet, we are working in Bombay, we are still better off that we can probably get away with a replacement and the patient will be happy to really use a table chair support life without any education. So I think geographical area becomes a major factor in treatment. But non-union with the head gone and everything, there is no option except a replacement. So when to do a replacement is also the issue, which we'll be discussing all that. Replacement, abduction, osteotomy, non-union, everything will be there. So fracture echo fever, last time it gone on for 4 weeks. This time also I'm sure it will go on for 4 weeks. Even if it goes for 8 weeks, I don't think any one of us have any objection with the time. We can do a fruitful knowledge.
What is the post-op protocol, sir? You start immediate weight bearing?
Normal question. I give the first answer. The other way, which I've been giving all the time, that forces applied on the hip are more in passing stool in bed than walking about. So walking about with the fracture which is in a good fixation is not contraindicated. And in an elderly person, you cannot walk on a one leg. Some patient, probably you can walk on a one leg. In India, we depend quite a lot on a non-weight bearing. But the fixation, if it is a good valgus fixation, weight bearing is not going to hamper the healing process. And if it is a varus reduction, hip spica also is not going to salvage the position. Asim, your views on that?
They are allowed weight, they call it weight bearing as tolerated with the help of walker. So they are taking as much as they want. There is no partial weight bearing or any instruction that is 15 pounds or something like that. If I have done a DHS, they are all walking next day with water.
Dr. Chandok, you want to add up anything about weight bearing?
Yeah. So weight bearing is actually decided by 3 important things. The stability we have obtained, whether you are age of the patient, and the ability of patient himself to get out of bed and support himself. So elderly patient may require 1 or 2 person on the side assisting him to come out of bed, to stand, to develop adequate quadriceps forceps, and then we give him weight bearing. A young patient would be out of bed next day itself if pain is not a constraint. However, most of the patient for first 2 or 3 days are more painful. But as a principle, they should be out of bed, they should be touching the floor, they should be passing some amount of weight on the limb. Otherwise, a profound osteopenia develops, which is detrimental for ultimate outcome. So they must start weight bearing. It is not complete unsupported weight bearing. It is a weight bearing with support of a walker. And if the construct is transverse and very stable, they can pass as much weight as they want, is what my concept about weight bearing is.
Sangeet, what is your idea about a toe touching weight bearing, which some people advise?
Sir, with the newer concept, having anatomically reduced the fracture and you have locked with a non-collapsible implant, like a fully threaded screw, probably that situation is safer to start a partial weight bearing as tolerated.
Okay, friends. I think there will be a very exciting talk by Dr. Sangeet, which I think he is first time I heard, I myself was excited. I must have heard 3 times, and every time I hear it is excited. Investigations and why you operate onto the anatomy of the structural anatomy of the neck. He will be talking about it probably not the next week, but the week after.
Vascularity.
Vascularity part.
So,
yeah. What do you want to add? Namrata?
So my question is actually to Asim, sir. So he had mentioned about an acceptable non-anatomical kind of fixation with neck of femur. Could you please repeat that? You said it was kind of similar to a medial cortical beak in intertrochanteric fracture.
Sorry, can you repeat the question?
He said it,
Positive reduction.
opposite. Yeah.
Positive reduction in a neck femur.
Yes, sir. A positive reduction. Something akin to positive medial cortical beak, which you have in an intertrochanteric fracture.
Everybody has agreed with anatomical reduction. In an intertrochanteric, we'll come to that positive reduction part of it. In a transcervical, the anatomical reduction is considered to be the best possible option which you have. Anybody has a different view on that?
So what Dr. Asim Negi was talking about was, Dr. Asim, you are there. Can you answer that? The question is directed towards you. If yeah.
And sir, I'm sorry. Can you repeat the question?
Yeah. What Namrata wants, you can repeat, Namrata. Yourself.
Yeah, sir. Actually, Tanna sir had shown us an X-ray of posterior tilt of a neck of femur fracture.
Yeah.
So when you were talking about that X-ray, you kind of commented that a certain form of non-anatomical reduction may be comparable to a medial cortical beak.
Is reverse of what is considered nowadays good in IT, which means on the lateral view, sir's slide with the red arrow was showing head fragment 1 or 2 millimeter behind the posterior border of the shaft fragment.
Yes, yes, sir. Yes, sir.
That's bad.
Okay, sir.
The other drawing, the extreme right, which wasn't an X-ray, it was a drawing that was showing head posterior border was 1 or 2 millimeter anterior to the posterior border of the shaft.
Right. The one with the hook nose, sir?
Yeah, the neck should hug the head. And on the AP view, again, same is true. If you cannot get anatomical, then inferior border on the AP view, inferior border of the shaft fragment can be 1 or 2 millimeter below the inferior most border of the head.
Understood.
Supporting it from below.
Got it, sir. Thank you.
So it's the reverse of IT.
Understood.
Dr. Sangeet has beautifully suggested that we do not know majority of the people who are attending the course. So if you can introduce yourself by putting up the video on so that we'll know about it. Dr. Nitin, you have a question?
Sir, I got a question about the capsulotomy. When we do closed reduction and internal fixation, do you always advise capsulotomy to reduce the temporary effect?
When you do the open reduction, you capsulotomy.
Share your screen.
Closed reduction.
Yeah,
closed reduction.
Sir, can you unshare your screen so that we can see everybody?
You please, all of you, put your video on so that we can see everybody, and please introduce that Dr. Sangeet that very nicely suggested. I think removing, when a closed reduction you achieve, opening up the capsule to decompress the hip is not being accepted as a must nowadays. At one stage, it was considered to be a necessity, but nowadays it's not considered to be a must.
Okay.
If I can answer that, sir. So when we drill the outer cortex and we reach the fracture site, many times we find the blood coming out. So that itself releases the tension if the fracture is communicating with the hematoma.
Okay, can you please, all of you, introduce yourself with the video on? Then
Sir, you will have to unmute, unshare your screen.
Unshare your screen, sir.
Yes, I will stop sharing.
Yeah.
Please, all of you, introduce yourself in a few seconds. In which part you are? Can you start from the Nitin? He is here first, I think, to me.
Yes, sir. Myself, Dr. Nitin Patil. Right now, I am a professor at Krishna Institute of Medical Sciences, Karad. I am practicing orthopedic surgeon since 32 years. And for last 4 years, I was president of the Sangli District Orthopaedic Association.
You're working in Sangli? Where are you working? I didn't hear.
I'm working in Islampura, small town. But now, right now, since last 14 years, I'm working as a professor in Krishna Medical College, Karad.
Karad. Fine. Thank you. Yes, next person.
Good evening, sir. I am Rakesh Goel from Punjab.
Where are you working and what capacity you working?
I am working in near near Amritsar in Beas Hospital.
Okay, thank you. Next person.
Sir, I am Dr. from Raipur.
Sir, Kedar Agrawal.
Sir.
Kedar. What sir was saying
Sir.
was the word is
Sir.
Didar. The Urdu word for showing your face is
Kedar.
Didar.
तेरा मुंह तो देखा.
That is called Didar in Urdu.
Sir, love you. Sir, one question.
यानी पहले किधर से आए तू बता दे जरा इंट्रोड्यूस करो तेरो.
सर मैं रायपुर से हूँ, छत्तीसगढ़ रायपुर. I'm running my own hospital.
One of the senior surgeon in Raipur, very fond of life. He is full of life into the party after the serious meeting is over. Thank you, Kedar.
I came from Vietnam last days.
Lovely. Vietnam is a lovely country. I'm sure you enjoyed it. Yes, now.
Yeah. I've enjoyed a lot. Thank you, sir.
Introduce yourself. Dr. Maleshwara.
Sir, good evening, sir. I am Dr. Maleshwara from Vijayanagaram, Andhra Pradesh. Practicing since 25 years, sir. I'm having my own practice. 75 bedded hospital I'm running, sir. And I'm working as a professor in MIMS Medical College. So that's all, sir.
75 bedded तो अभी इतना पैसे को क्या करता है तू यार?
नहीं मेरा वाइफ तो गायनेकोलॉजिस्ट है और माय सेल्फ तो ऑर्थोपेडिक्स है.
ओके, डॉक्टर भारत भूषण.
Hello, sir. Myself, Dr. Bharat Bhushan Jangid from Ganganagar, Rajasthan, sir.
Good. Dr. Rakesh Golograd. Dr. Harjot Singh.
Good evening, sir. I am Dr. Harjot Singh. I am working in Mahasamund in my own private setup. And Mahasamund is a small town in Chhattisgarh.
Okay. Dr. Yogesh. You are muted. Dr. Yogesh, you are muted. You unmute yourself.
Yes. I am Dr. Yogesh Navangol. I am practicing in Kudal, Sindhudurg, Maharashtra. I have my own setup at Kudal.
Okay. Dr. Surjit.
Sir, good evening. Myself, Dr. Surjit. Sir, I am working in Government Medical College in Himachal Pradesh, sir.
Okay. How many years you are in practice?
Sir, I have recently joined as a new assistant professor.
Okay, Dr. Namrata. We can't see your full pretty face, huh?
You're muted. You're muted.
Hello, sir. Good evening to all of you. I'm Namrata Srinivasan. I'm currently working as a senior resident at Medical College, Government Medical College, Mysore.
Mysore?
Yes.
Dr. Aditya Sheth, unmute yourself first.
Sir, working as a fellow in arthroplasty at Sunshine Hospital.
Jaraya Sunshine.
Hyderabad, sir.
Guruva.
Guruva Reddy, sir.
Aditya Pandey. You are muted.
Sir, hello.
Yes.
Sir, I am Dr. Aditya Panda. I work in Bhubaneswar, KIMS Medical College as an assistant professor. I already done my spine fellowship under Dr. Sajan Hegde. I am working as an assistant professor in a medical college.
Good. Dr. Durgesh Patidar, please put your video on. We have to see your face. Yeah. And you are muted.
Yeah. Good evening, sir.
Evening.
I'm Dr. Durgesh Patidar from Barwani, Madhya Pradesh, working as an orthopedic consultant in a private setup.
Dr. Bhaskar,
Yes.
you are muted.
I'm not muted now, sir.
Yeah.
You are not. We can listen you.
Hello.
Yes,
Yeah,
sir.
yeah, we can hear you.
Sir, should I repeat?
Please.
Yes, sir. I'm Dr. Durgesh Patidar, orthopedic consultant at private hospital in Barwani, Madhya Pradesh.
Okay. Dr. Vivesh Singh.
Good evening, sir. I'm Vivesh Singh. I'm a senior resident in Sharda Medical College in Greater Noida.
Okay. Who is this admin? You are from OrthoTV?
Famous senior SR.
Dr. Suresh, you are muted.
Good evening, sir. I'm Dr. Suresh from Kodada. It's near Telangana. It's near Hyderabad. I'm practicing since 15 years. I have my own hospital, 20-bedded hospital.
Okay. Dr. Virji.
Sir, good evening, sir. I'm Dr. Viraji. I'm a student of Professor Dr. Sudhir Babulkar. I'm working in Jeddah, Saudi Arabia. I'm an orthopedic surgeon here in Saudi Arabia, working in Jeddah, Alamra Hospital.
Okay. Dr. Sri Harsha.
Good evening, sir. I am Dr. Sri Harsha. I am from Telangana. I am doing as a senior resident in government hospital Nirmal, sir.
Where is that?
In Telangana, sir.
Board doctor? Please board. Orthopedic surgeon.
Yes, sir.
Bolo Suresh. Dr. Suresh, Dr. T. Suresh, board.
Hello, sir.
Hello.
I'm Dr. Suresh, working as a consultant orthopedic surgeon at Shekar Hospital, Hyderabad, sir, under Dr. Akhil Gadi, sir.
Dr. Shashank.
Hello, sir. Hello, sir.
Yes.
Sir, I'm Dr. Sushant, sir. I'm MS Orthopedics, working in Manipal Hospital, Goa, as a resident, sir.
Manipal Hospital, Goa. Oh, yeah.
Yes, sir.
Dr. Sharat. You're muted. You're muted. Please unmute yourself.
Good evening, sir. Yes, sir, I'm Dr. Sharat Chandra. I'm working in Bangalore as a consultant in a private hospital. And I also visit many other hospitals.
And iPad.
Bangalore East. Sir.
Can you show your face, please? iPad. Who iPad?
Rahul Reddy. Unmute yourself, Rahul Reddy.
Rahul.
Hello, sir.
Yes,
Can you hear me, sir?
Yes.
Yeah. Good evening, sir. I'm Dr. Rahul Reddy, working as a consultant in a private hospital in Guntur, near Vijayawada, Andhra Pradesh.
Nice. Yes, otherwise, iPad.
Also there.
Good evening, sir. Myself, Dr. Nanasaheb Bhosle, working as a senior resident in MIMS Medical College, Latur, sir, in Maharashtra.
Mohammed, unmute yourself.
Realmpad. Who is the Realmpad? Muhammad Yasir.
Hi, sir.
Yeah.
Hello. I'm Dr. Muhammad Yasir, orthopedic surgeon from Basra, Iraq.
Yeah, we cannot see your face.
Yes, I will open just 1 minute.
You are from where?
So now, okay, good.
You are from where, beta?
Iraq.
Iraq, from Iraq, Basra.
Oh.
In the south of Iraq, this is Basra.
Thank you. Doctor.
Thank you so much. Thank you, sir.
Can we see your face, please? Kimi Kowalski. Dr. Kasper. Yes,
greetings from Poland. I'm a senior resident in Toruń.
Dr. Karan Rajpal.
Good evening, sir. I'm working as a third-year senior resident in Ambedkar Medical College, sir, Delhi government. It's a Delhi government medical college, sir.
Who are remaining? Dr. Dhirendra Kumar.
Good evening, sir. I am Dr. Dhirendra from, I have done my PG from M. Jodhpur in 2021. At present, I am working in Moga as a orthopedician near Ludhiana in Punjab.
Dr. Satya. Dr. Satya, are you there? Dr. Nageshwar Rao? Not there. They opened up the thing about. Dr. Vijay Vaghmare?
Excuse me, sir. I want to introduce myself. My name is appearing as admin, but I'm not at all related to OrthoTV. I'm Dr. Nitin Agarwal from Bijnor, UP, the place near Haridwar, the Tier 3 city. Am I audible?
Yeah,
very much.
Thank you.
Next one, I don't know, 7C266103. है कोई ऐसा? Dr. Abhishek Rapte. Abhishek.
Hello, sir. Am I audible, sir?
Yes.
Yes, sir. Myself, Dr. Abhishek Rapte, sir. I'm a registrar in Rajawadi Hospital, sir. Currently working, sir. And attached to some nursing homes, sir.
Bombay.
Yes, sir.
Okay. Yes, 7326.
Good evening, sir. I am Dr. Prashant.
From?
I am from Kerala, sir. Calicut, Kerala.
Okay. Dr. Satya, are you around? Aniruddha Deshmukh?
Hello. Hello, sir. Doctor, I'm Aniruddha Deshmukh, based in Pune, sir, working as an orthopedic surgeon, attached to multiple hospitals, sir.
Thank you. Dr. Fleming? Dr. Pankaj Kumar? Dr. Sharath? Dr. Ami Mehta? Dr. Ami, you are there? Can you unmute yourself?
Thank you. I'm Anisba from Indonesia. Thank you for give me a chance to get a fellowship from India, especially in trauma. Thank you, sir.
Dr. Fleming? Pankaj Kumar?
The sound is not clear enough, sir.
Indonesia, where? Which part of Indonesia?
I am in Central Java. Yes, 200 kilometers from Jakarta.
Okay. Anybody else remaining whom I have not been able to see here? Dr. Vivesh Singh, have you introduced yourself?
Yes, sir. Senior resident from Sharda, sir.
Okay. Okay, friends. Anybody remaining who is there to be introduced? Asim Negi. Indore. He is Dr. Sangeet, Mumbai. He is Dr. Chattok from Nagpur. Okay, friends. Thank you very much. We meet next Thursday.
Thank you, sir.
Bye-bye. Bye-bye.
Thank you, sir. Thank you, sir.
Thank you, sir.
Bye. Bye-bye.
Good night, everyone.
Thank you, sir. Thank you.
Thank you. Thank you, sir.
Thank you, sir. Bye.
OrthoTV, we can now close down the recording.
Thank you, sir.
Thank you. Bye-bye.
Give you my appreciation from Indonesia.
Jadi rupa saya mana dewa tu? Positif tadi. Ini rupa cakap pun, ठंडा ये rumah. Hah? Kuburan lak. Terus mau aja kamu. Putu aja na, baik putu. Hah? Hah? Kuku tak kalah 2 hari kapan?
Huh? Hmm? Hmm. त्याची माझ्याकडे कळलं पाहिजे. हा हा आज तू चांगलं आहे ना आता चांगली झाली ना हम्म. हम्म. मग कसं जाऊ काय तुला